This is Migraines in 5 minutes, primarily geared towards family medicine and potentially pain medicine, that initial treatment for migraines for patients that are struggling. I'll start with the way that migraines were taught to me in my graduate studies. It was presented as a spectrum from tension headaches, something that most people have experienced, to migraines that can be very disruptive, sometimes makes it difficult to drive, things like that, to cluster headaches that can be completely debilitating and disabling. And what's important for you to know is that you don't need to know any of that. There's a lot more types of migraines to be aware of in a neurology type setting, a specialty setting, but from family practice perspective, you can use this same treatment algorithm and do a pretty good job. A lot of people wonder what's the difference between a migraine and a headache. And medically speaking, the technical difference is that a migraine is anything that has sensitivity to light or sound. And that's a big gray because people can have tension headaches and have sensitivity to light and sound, but they're not dysfunctional with that pain. So I just call everything a migraine because when you're charting, you are going to diagnose it as a migraine because that's how insurance will cover the medication. And it's as simple as that. The algorithm, what you came here for, is like anything with pain, Tylenol and ibuprofen is going to be your first line. And with migraines specifically, they do have a migraine-specific pain medicine known as Excedrin. What is Excedrin? It's Tylenol, ibuprofen, and caffeine. It's actually Tylenol, aspirin, and caffeine, but regardless, it's an NSAID, right? Tylenol, an NSAID, and then you can add caffeine to that. And you might be saying, I thought caffeine was bad for migraines. No, caffeine is a vasoconstrictor. So people with migraines, they can literally feel the blood pulsing in their head. And vasoconstrictors squeeze down on those arteries and get that blood flow away. The problem with that is if you use Excedrin for more than 3 days in a row, or you use caffeine excessively and then stop, then you've vasoconstricted, then all of a sudden you open up the floodgates. So you may be suppressing a migraine, and then once you pull away that vasoconstrictor, you end up with a worse migraine than you were even suppressing in the first place. So with migraines, you do want to cancel about lifestyle, and the 3 big ones are S and M. S and M. Sleep, meditation, which is just related to stress. So you're trying to deal with sleep stress, and the A is for aqua, water. 2 liters of water a day or 4 water bottles, and 8 hours of sleep, obviously. And another important counseling point is sometimes you can't help stress. Sometimes you can't help weather. Some people are triggered by weather. Sometimes people have really bad neck issues that are causing their migraines. Sometimes it's just their kids and you can't get rid of their kids. But if you can't treat the cause, you can still treat the symptoms. And a lot of times we can't eliminate the cause for their migraines, but there are a lot better treatments available now than there were before. So let's talk about them. There's 2 ways to treat migraines essentially. There's dealing with the blood flow issue, or something that we've just recently learned about in the history of medicine in the last 5 years or so, CGRP, which is a protein that builds up in people with migraines. With the blood flow, there's something known as triptans. These were the very first medicines available by prescription for migraines, and they're cheap, and insurance usually wants us to start with this. However, the majority of people presenting for migraines are women in their childbearing years on birth control. And you don't really want to use a triptan in those people because with the birth control and a triptan, that increases their risk of stroke. And if they do get pregnant or they're planning to get pregnant, triptans are, they can constrict the placenta, and so that's bad for the fetus. There are also ergots. Ergots work in a similar manner of vasoconstricting, same way as caffeine, but ergots are a bit more expensive and have all the same contraindications. Same with older people, history of heart attack, stroke, hypertension, all those contraindications to triptans. They're just so prevalent because they were the only thing we had for a really long time. And then you've got your CGRP blockers or antagonists, and those and Ngpant. However, these are all name brand right now, and that's Nurtec and Ubrelvy. And then that's for abortive or as needed. Abortive medicines you do have to use within 2 hours of onset for them to be effective. The sooner the better. Then there's preventatives. The general rule is if they've had more than one a week or for a month, then use a preventative. Drug reps trying to sell you preventatives will say if they have even just 2 migraines a month, use a preventative. I say even if they have catamenial migraines, which is migraines during their menstrual cycle, and it's every single time and they're missing work once a month, that's still enough to justify a preventative. So there's cheap preventatives that they're not made for migraines, but they kind of deal with this blood flow aspect, and those are beta blockers. Topamax is an anticonvulsant and is a sodium channel blocker. And then there's amitriptyline, which more so it's a tricyclic antidepressant, but it addresses the blood flow aspect with its alpha activity, and then it also kind of addresses that mood aspect with the way it affects serotonin, because there's a large overlap between migraines and mental health as well, which is why I pointed out the whole stress aspect. And then there's CGRP preventatives that are in the form of monoclonal antibodies. Of course, all monoclonal antibodies are injectables, and these all end in ezumab. However, these are all like name brand right now. So you've got Emgality, Aimovig, and Ajovy. And that's it.